Hi, Unbroken. How are you doing? Welcome, welcome, welcome. We're gonna do our questions tonight. How was your day? Eh, Work was good. Was good. Wasn't that bad. Saw my 5 patients and left. Cedar Hill. Saw my 5 patients left Cedar Hill. Angela, how are you? Okay, good. What are you up to, Angela? Okay, nice. Yeah, let's share up the live. Give the video a thumbs up. Let me try to get a little bit more. I really need more light around here, so because only 2 minutes may I stay for. 2 minutes. I'm staying around this side for. Yeah. Okay. I'm waiting for a few more persons to come on to the live. And then we will go through our questions. Still holding on for that flash drive for Christmas. Okay. You know them say wait kill man though? Eh? What else we say? November. Remind me November. November. It's 209. Okay, nice, nice. Yes, guys, let's tap up the live, share up the live, send it to your friends. Oh, I've repost it to my page. Add it to my story. So my friends can see that they're on the live here. Ellie, how are you doing? Yes, them so weird kill man. So you understand? Where you come from Jamaica, so you're supposed to know. You come from Jamaica, no so? You're supposed to know. But as I say, you can remind me in around November thereabouts. And I will try to see if my pocket can stretch. Okay? The one good deed. Where am I thing there? Yeah, so I'm gonna do some pathophysiology questions. And we'll try to do, I think I have about, how much questions? So it's about 21 page. Okay. About 21 page. Let's say about 20 questions or so, 30 questions. You like the new scrubs? You know, when I buy them the other day though. And I bought them for my new job. Because I kind of get tired of the navy blue and the royal blue. So I was trying out some other colors. But I can't find myself wearing them yet. So that's just it. No, you have to go down the yard for go learn patois. Yeah, they're live. So, Zorin is saying hi. Okay. Amen. Uh-huh. My favorite must be is illustrated help. Okay, Christopher, nice. Nice. Pets, welcome. Yes, I'm doing some pathophysiology questions tonight. So we're going to do some pathophysiology questions tonight. I was going to do some lab related as well, but I don't know. Time is not going to allow it because I have so much things to do after I finish the live. So it's just for NCLEX. NCLEX, but I have some NPs who are on the live as well, so it will help everyone. So once you're a nurse, nursing student, LPN, RN, it will help. Where in Jamaica you from, Pet? Pet was my hairdresser in Jamaica. She didn't miserable though, you see? Yeah, because she always tell me some hair course. But yeah, she was a sweetheart. Oh, you're in Florida? Okay, nice. All right, let me turn this around. Oh, you're from Clarendon? Okay, cool. I come from Manchester. South Manchester. All right, let me turn around this and then I'm not gonna tell me put on the filter. Oh Lord, I'm not gonna tell me. Oh Lord. All right, let me go ahead and turn the camera around so can start seeing the question. Yes, we're neighbors, we're family. All right, let me turn the camera. And all you need to do is just remember to tap up the screen, tap the screen, so you know TikTok and YouTube can understand the algorithm and know that, yes, we need crowd over here, and share and follow. And if you miss the live, so for example, you decide to leave and come back, the full length of the live stream will be posted on YouTube. So you can feel free to go over there and watch them at your own time and convenience, okay? Thank you, Ellis. Welcome, welcome, welcome. Zarian. Okay, and then let me turn this one. Thank you for topping up the live. And we all can see it clear, right? Clear as mud. Oh, this has some look very familiar. Dark chocolate. I see a big smile. I'm gonna have to look you up, dark chocolate. You're from South Manchester as well. Okay. You come from Cross Keys? I probably know you then, man. Pass through Cross Keys. I used to go to Manchester. Zarian. Hold on there, let me get this little young man outside. Zarian, please go to your bed. Come. You see, my friends, they're not happy right now because you're moving my projector. Oh, you went to DC? We're probably riding on the same bus. Okay, so first question. A patient with left-sided heart failure develops pulmonary edema. What is your primary pathophysiologic reason for this finding? As I say, all the questions are pathophysiology related, okay? So we're gonna try to remember the pathophysiology behind the conditions. So a patient with left-sided heart failure who develops pulmonary edema. What is the primary pathophysiologic reason for this finding? Pet says A. I remember we need competition on the board, okay? We need to see what you guys are thinking. Anybody else? Christopher says B. Mikis, it's the first time I'm seeing you. Welcome. Mwani, welcome. I think I first messaged Pet to you know. Holy File, welcome again. Oh my word, this thing falling. Oh, let me move this over. Okay, so AAA. Okay, so increased hydrostatic pressure in the pulmonary capillaries. Dark chocolate says decreased preload causing fluid shift into the lungs. So a patient with left-sided heart failure develops pulmonary edema. What is the primary pathophysiologic reason for this finding? Increased hydrostatic pressure in the pulmonary capillaries. So you have left-sided heart failure results because of what? The blood backing up into the pulmonary circulation. So you have increased hydrostatic pressure, fluid leaking into the alveoli, resulting in your pulmonary edema. So always think of, you know, the fluid backing up for your heart failure. And when you think of left-sided, you're thinking about what? So when you think of left-sided, You're thinking about the lungs, right? And for the right-sided heart failure, what are some signs and symptoms for right-sided heart failure? What are some signs and symptoms for your right-sided heart failure? JVD, jugular vein distension, S3 sounds, edema, peripheral edema. Good. Edema, JVD. Anything else? Hyperlipidemia, swollen ascites, Mel. I haven't seen you in a while. Okay. Nikki says fluid retention. Good. So if you were supposed to be treating left-sided heart failure or heart failure in general, what kind of medications you'd be anticipating? What kind of medications would you be anticipating for the treatment of heart failure? You can go ahead and just list it. If you were supposed to be treating heart failure, the doctor is going to be treating heart failure. What are some medications you can think of that they could be ordering? Diuretics? Yes. And if you were supposed to choose between your osmotic diuretic and your loop diuretic, which of the diuretic would you choose? So oxygen, anticoagulants, good. I have ARBs, loop diuretic. Yes, you choose your loop diuretic. Good. Lasix, yes. All right. Let's move on to this one here. Why do patients with DKA develop metabolic acidosis? Why do patients with DKA develop metabolic acidosis? A, insulin resistance causes lactic acid buildup. B, fat breakdown leads to ketone production. C, excess glucose increases bicarbonate levels. Or D, dehydration causes respiratory alkalosis. Anna Janiel Pet says B. Ernest, welcome. Nice having you. B. Hussein is questioning whether or not it is B. Marissa says C. Why do you say C, Marissa? Why C? What is happening with your patients in DKA? What is happening with your patients in DKA? So DKA is associated with what? Type 1 or type 2 diabetes? Marissa, you still here? Azzy Monroe, yes, type 1. It's associated with type 1. And what we know about type 1 diabetes, what is happening in type 1 diabetes? Moni, welcome. Diniqua. I see a lot of ketones, okay. How do we get the ketones? Marissa, when I see you yet, you hide out. Huh? I use to see you now, so I see you. Where you there? So DKA, extremely high sugar levels, so hyperglycemia. Yes, so you have the ketones from the fat breakdown. Yes, Janiel. Okay, so due to fat breakdown, since no glucose, which is needed for energy. Good. So you have your fat breakdowns. Because of the insulin deficiency there, your body resort to the fat, and so you have that breaking down into ketones, which is very acidic, resulting in metabolic acidosis. So your patients tend to be in metabolic acidosis, and this is something that is pretty common. You'll find on the NCLEX exam. So if you don't know, you don't know it, just remember that your DKA patients are always in metabolic acidosis. Okay, HHS does not produce significant ketones, and that's a key difference. So they produce small amounts, but it's not a significant amount. Thank you, because I need questions. I just finished this week's reading on diabetes. Okay, no problem. So if you have this patient that is in metabolic acidosis, you have a patient in DKA, metabolic acidosis, which system is being affected here? What system is being affected? So you have this imbalance taking place. What system is being affected here? What system is being affected here? Pustain says kidney, mainly says kidney. So the imbalance, the metabolic acidosis. So metabolic acidosis, their imbalance, the kidney. Okay, good. So if the kidney is being affected here and they're supposed to be compensating, what system will be compensating? So you know the acid-base imbalance. There are two systems at play there. So if the kidney is giving problem, the patient is going to be blowing off with the respiratory, the lungs. Good. And that's why you're going to have the cosmol. Leanna Smith, yes. Respiratory. Good. So why do the patients with DKA develop metabolic acidosis? Because of the fat breakdown, which leads to your ketone production. So you have a patient in DKA, metabolic acidosis. What is your priority for this patient? What is the priority for this patient? You have a patient in DKA. What is your priority for the patient? Hydration, fluids, good. Yes, so the patient needs fluid. And if you're supposed to be giving the patients a lot of fluid, you're going to be giving this patient a lot of fluid. What fluids you'll be thinking about? What kind of fluids you'll be going for resuscitation? Your isotonic solutions, your 0.9 saline, sodium chloride, yes. Correct the insulin deficiency. So you want to make sure you resuscitate them, make sure their electrolytes. Yes, you go with your normal saline. Because these patients are dehydrated, so you want to make sure that they're perfusing properly. Circulation is good. Then you go ahead and, you know, correct the glucose after. All right, let's go on to this question. Which pathophysiologic change causes CO2 retention in patients with COPD? Which pathophysiologic change causes CO2 retention in patients with the COPD? A, increased alveolar ventilation. B, thicken alveolar membranes. C, decreased diffusion capacity. Or D, hyperventilation from hypoxia. Which pathophysiologic change causes CO2 retention in the patients with COPD? D, C, soft girl vibes, I see you. Welcome. Soft girl says, wait, not C. What are you saying, soft girl? So D, hyperventilation from hypoxia. Still waiting for soft girl to make up our mind. K-Chel says C. So COPD causes hypoxia or something like that. That's why I chose. So as in not so sure either. Okay, so Pustain over there so says D. Gavin says C. So which pathophysiologic change causes CO2 retention in patients with COPD? As it says, I pick D. Hyperventilation from hypoxia. What we know about COPD? What we know about COPD? Real Nicole's World says C. Decreased diffusion capacity. Oh, under pressure. Azzy. Okay, Glitterbox D, Yan Yan. Pamela, C, good. So remember you have the alveoli that is being damaged in your COPD, okay? So you're gonna have decreased diffusion capacity, so you have the CO2 that is being trapped. I did that 2 classes ago. Period. Gavin, welcome. Good. K-Chell, welcome. So which pathophysiologic changes cause the CO2 retention? What is causing the CO2 to be retained? Everybody's saying D. Had me second guessing. Okay, who is this? Real Nicole's World? Nay says B. Okay, thickened alveolar membranes. That's, remember you have damage to the damage to your alveoli. Okay. So that is what is causing the problem in COPD. So you have the damage, and so you have the problem with diffusion there. So you have COPD, the CO2 being trapped. Okay. So the oxygen moves slower in. So CO2 comes out slow. If you have a patient with COPD, what oxygen, how much liters of oxygen you can give them in terms of the max? What's your max on your oxygen for those patients? How much liters you're comfortable giving, or you're supposed to be giving those patients, seeing that they're COPD? $10 to $12. So 2 liters, good, up to 2 liters, 3 max. So 88 to 92% for your oxygen saturation, good. And if you were supposed to be giving them, what is the best in terms of device, oxygen device, in terms of giving them the, in terms of concentration? What would have been the best device to use for your COPD patients? Your venturi mask. Because you actually can, your venturi mask. Lip breathing. Yeah, because you can control the amount that you give them with the venturi mask. You set it and just leave it. Precise FiO2. Maria RRT, welcome. Thank you so much for tuning in. Okay. Let's go on to, I never see it. A patient with dehydration develops pre-renal acute kidney injury. What is the underlying pathophysiology as it relates to pre-renal kidney injury? Yeah, because I don't see it already. Yeah. And then, what's her name? Kijim J. I put C with an exclamation. Yes, because I don't see it already. Let me just show you the answer. Yeah, I want to see it already. So, a patient with dehydration develops pre-renal acute kidney injury. What is the underlying pathophysiology? A, direct damage to renal tubules. B, obstruction of urine flow. C, reduced renal blood flow. Or D, autoimmune destruction of nephrons. So we know that pre-renal, anything with pre, we know before. Okay, so before the kidneys. So you have decreased perfusion, leads to decrease in the glomerular filtration rate. And that's how you have your acute kidney injury. Oops, it's me, it's her. Welcome. How is your night shift going? So just think no blood, no filtration going on. Okay, so for your pre-renal, what are the different stages of kidney injury? So we already talked about pre-renal here. What are the different stages of your kidney injury? We have pre-renal. What are the others? So we have pre-renal, intra and post. Okay. So for your intra-renal, what are some causes? What are some causes for your intra-renal kidney injury? What are some causes for intra-renal kidney injury? Medications, contrast, direct trauma, contrast dye, good. Vancomycin, yes. Direct damage to the renal tubules for intra. Good. So when you think of your medications, what is very, very important for you to do when you're, so for example, vancomycin there, what is one thing that you definitely need to do? Check for your patients before administering vancomycin to patients, because of the fact that it can cause injury to the patient's kidneys. Take your BUN and creatinine. But if you only have one test to do, which one is the most important one between the BUN and your creatinine? Which one of them you definitely need to get? Is it the BUN or the creatinine? Which one? The creatinine, yes. So always make sure you look for your creatinine, and if there is any slight changes to that, then you withhold your medication, okay? A lot of times your BUN, it can be increased, sometimes because of dehydration, sometimes they'll give the fluids, it will correct itself. But your creatinine, any slightest changes to that is a problem. So always go ahead and let your provider know. Okay. What about your post-renal? What are some reasons why you can have post-renal kidney injury? What are some of the causes? Obstruction, Kiki, welcome. Sexinisha McBean, welcome. BPH. What's BPH? NSAID, kidney stones. I see BPH a lot. Okay. Yeah. We see the prostate. Anything else apart from the prostate and the kidney stones? Hyperplasia. Yeah, blood clots. Sometimes the patients can have in their catheter and they can have clots there that can cause them to have post-renal. Yes. Yes, Eliza. Okay, good. So let's go down to cancer is one of them, sex initial, BPH, UTIs, tumor. Okay. Why does sepsis cause hypotension? Why does sepsis cause hypotension? Liana, Elias. Yeah. Why does sepsis cause hypotension? B. Princess A. Okay, so I'm counting from Prince. Princess B. A. Okay. Kate Shell says 2 net says A. Increased cardiac output. What is happening? Think of sepsis. What is the pathophysiology behind sepsis? What is happening in sepsis? What is happening in sepsis? B, widespread vasodilation. Okay. That's how the patient becomes hypotensive. So infection of the blood, the cause, yes, glam. That's the cause. But in terms of the pathophysiology behind it, how does the patient get hypotensive because of that infection in the blood? That's what we're trying to figure out. How does the patient get to sepsis, but they can't find the infection anymore? So you have that massive vasodilation. So you have inflammatory mediators results in massive vasodilation and the capillary leaking. So you have systemic vascular resistance decreasing and you have hypertension going on. So what is very important for this patient? What is priority for this patient? So you have a patient here who is in sepsis. What is the priority for this patient? What is the priority for the patient? And when we say priority, what is the one thing that the patient needs to correct? The hypotension here, the problem. The pathophysiology of the problem. Fluids. We go back to the same fluids again, okay? So the patient needs the fluids. Why not the antibiotics? Isn't the sepsis caused by the infection? Why you never said that the patient needs the antibiotic? Huh? Why not the antibiotic? The patient needs the antibiotic. Because you give the patient the antibiotic, yes, what is going to happen? The patient still doesn't have any circulatory volume. So antibiotics won't fix the low blood pressure. Exactly. The volume is low, so it's not going to fix the hypotension that is taking place right there because of that infection on board there. So you want to fix the hypotension, fix circulation first, and then you go ahead and deal with the infection afterwards. When do we go ahead with pressors? So doc, you have a patient with a blood pressure of 70/30, and the patient is there. The map is, let's say the map is 46. And you have the patient with 1 liter of fluids, and you already gave 250, and you're repeating the blood pressure every 5 minutes, and the blood pressure is still hanging out at 70/30 for the last 5 minutes. What are you going to be doing? Are you going to be giving that pressor, or when are you going to give the pressor? Fluids not fixing hypotension. If they don't respond to fluids, you give pressors. Yes. So make sure you give all of your fluids, and then from there you jump onto your pressors. So always start with your IV fluids, then you go on to your pressors. Call the emergency hotline, Jesus. Amen. Yes, Jehani, you call that number. Well, you call his name. Okay. So you have this patient with sepsis. You have this patient with sepsis. We're already given the fluids for circulation. Okay. What else are you anticipating? What else are you anticipating for this patient? What are you going to be getting for this patient? The doctor says, hey, Glam, I see you over there laughing. I want to go ahead and take control of this patient. Run the show. What are you going to be getting for this patient that is hypotensive with you? Yes, you too. Oops, it's me and Nikki. What are you going to be doing? So you have a patient in sepsis. What are you anticipating? The doctor is tied up doing a CPR over that side. Okay? And you're supposed to be getting certain things going. What are you going to be doing for the patient in the meantime? You already get the IV and the fluids going. Earlier, I couldn't get the blood because it was a hard stick. So, what are you going to be doing? Vital signs. Hello, hello, Lorena. Welcome. Ashley says she's going to get the glucose. Okay, okay. All right, we get the glucose. The glucose is 100. What else we getting? Positioning in bed. All right, patient prop up in bed. Antibiotics, good. You get your labs. What kind of labs are you going to be getting for this patient? There's one thing that I wanted to make mention of for your labs. What lab you're going to be getting that is very, very important. Angus says your lactic acid. Bam Bam says trough. Why are you getting trough, Bam Bam? Lactate. You're going to get your lactic acid. You get your blood cultures. Yes, when do we get our trough levels? You have a patient that just comes into you. Patient is not on any antibiotic. When do we get our trough levels? So they would have already been on the medication. They would have to be on the medication, and then you would go ahead and get it. Yes, so you have to administer antibiotic for a while, and then you'll get your trough levels later on. But you earlier, like, you know, when you're doing your sepsis workup, you're not going to be doing trough levels like that. You'll do trough levels probably like the next day or so. All right, so that's not like priority, but you definitely want to get your lactic acid. Why the lactic acid is very important? I see a lot of persons did put it down. Why is the lactic acid very, very important? Okay, the next day. Why is the lactic acid very, very important for your sepsis patient? It shows perfusion. Good. But what about the pulse ox? What about the pulse oximeter? What about the pulse ox? What about the map? If lactic acid organs, need to do. You need to do your intake and output as well. Definitely, you definitely need to do your strict intake and output for your patients. If lactic acid. Yes, it's good to have your indwelling catheter. So between your lactic acid and your pulse oximeter or your O2 sat and your map, which one is, like, you know, a better reading in terms of perfusion when it comes on to sepsis? You're back to your lactic acid. You'll go back to your lactic acid. Because you can still have a patient that is, the map can be good, but the lactic acid is still not, the patient is still not perfusing well. Okay, so always stick with your lactic acid. For your map, your mean arterial pressure, what is your goal for your mean arterial pressure? What is your goal for your mean arterial pressure? Your map, what is it that you're looking for? So anything greater than 65 for your mean arterial pressure. Yes. Good. Okay. Are we missing anything on? And always remember to get your 2 large bore IVs for your sepsis patient. To get them on your cardiac monitor. What else? Oh, someone was asking about the glucose. Is the glucose important for your sepsis patient? Is the glucose important for your sepsis patient? CR says yes. Okay. When is it very, 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 very important? Yes, if it is shock. Yes, because it causes hypertension. Ashley. Your stroke patient, your DKA patient, if it is shock. It's important for your DM patients, yes. Hyperglycemia versus immune system. Your diabetic patients, yes. It's very, very important, especially for those diabetic patients. Good. Okay. Decreased level of consciousness, yes. What occurs at the cellular level during an ischemic stroke? What occurs at the cellular level during an ischemic stroke? A. Increased ATP production, adenosine triphosphate production. B. Enhanced glucose metabolism. C. Increased oxygen delivery to neurons. Or D. Neuronal swelling from sodium influx. What occurs at cellular level during an ischemic stroke? Thank you for liking up the live, guys. Remember to follow, like up the live, and share. Okay, so I see AA, C, D, Clarice, Sharice, D, Fatma, Rog, welcome. Fatma, welcome. Layla, welcome. First time seeing you guys. JP, welcome. So what occurs at the cellular level during an ischemic stroke? Neuronal swelling from sodium influx. So no oxygen, resulting in the ATP failure. Okay, sodium and water entering the cell, resulting in swelling and death of the cells. Katie, yes. So you have neuronal swelling from sodium influx. CR says D, so close to A. Increase ATP production. Okay. So you have a patient that comes in with stroke-like symptoms. You have a patient that comes in with stroke-like symptoms. What is one thing that is very important for you to do for that patient? You have a patient that comes in with stroke-like symptoms. What is very, very important for you to get for that patient? Last known well, your fast assessment, and your glucose. Yes, the time it started. You definitely want to get your blood glucose. So most important, so when your patient comes in, you want to make sure you get their last known well, but most important thing is their glucose. Because why we getting the glucose? Why the glucose is very important for your stroke-like patients, the stroke symptoms. Neuro checks, okay. Why it's very, very important. Check your glucose. Hypoglycemia can resemble stroke, yes. It can mirror your stroke symptoms. So you want to make sure you go ahead and prick that little finger, okay, to make sure that patient is not hypoglycemic. Then from there, get your patient over to CT. Can't have ATP with low glucose. Confusion, hypo. Yes. So you want to make sure you get that patient over there and get their scan. All right, let's look at this one. Why does hypokalemia increases the risk of cardiac arrhythmias? Why does hypokalemia increases the risk of cardiac arrhythmias? A, increased myocardial contractility. B, faster action potential firing. C, delayed repolarization of cardiac cell. Or D, increased sodium channel activity. So why does hypokalemia increases the risk of cardiac arrhythmias? Let's see, A. Who's that? C, Elysia, Yan, S&B, Essentials and Services. Love, Irene, Faith. Welcome. So why does hypokalemia? What we know about hyperkalemia? So we know what we know about hyperkalemia. So if we know that hyper is fast, excitability, and we know we have hypo, then what we're gonna have? Everything is gonna be what? Slow down. So low potassium. Everything's down, delayed repolarization. So low potassium causes delayed repolarization, and that is very unstable, okay? So you have cardiac rhythm, arrhythmias taking place. So that's delayed repolarization, yes. Both of them. We're looking at the pathophysiology behind. Both of them are increases the risk for cardiac arrhythmias. Both of them increases the risk for cardiac arrhythmias, but hypo, as it relates to the pathophysiology behind hypokalemia, it's gonna be because of the delayed repolarization. There, no, both of them. Yes, S and B. So the answer is gonna be your C. Yes, Nikki Pustain. C, good. Increased myocardial contractility would be associated with what? Increased myocardial contractility would be associated with what? Hyper, Anita, yes. It would be associated with your hyper. Faster action potential firing would be your hyper. Increased sodium channel activity is going to be hyper. Hypernatremia, Daniel. Good. So, definitely get the patient on your cardiac monitor. And you want to give what we're going to be doing for this patient. So how you're going to treat your hypokalemic patient? Are we going to do the IV push potassium? How many persons going to do IV push potassium? How are we going to do IV? How are we going to do the potassium? Yeah, we're not going to wing no potassium. We're not going to count any drip rate. We're going to get it onto the pump, okay? We're not going to wing it. We're going to put it on a pump and get the correct rate going. Where K-oxalate come from? When do we use K-oxalate, Candy? Michelle, I see you put it in the chat. K-oxalate. When do we give K-oxalate? Yes, you laugh out. Yes, so K-oxalate is for your hyperkalemic patients, a high potassium patient. So when they have too much potassium, you give them the oral K-oxalate so they can poop it out. All right, but that's not for the emergency. You're not gonna give that on that emergency because that's gonna take probably they start pooping tomorrow. You need something that is gonna work today. So if you're gonna be giving, so if you're seeing that you bring up K-oxalate, so if you're gonna be treating your hyperkalemic patient, what are you gonna be treating your patient with high potassium with? You have a patient that has high potassium, Candy, you already say K-oxalate, you already give the patient K-oxalate, patient is going to start pooping tomorrow. What else can you give your patient now to start working? Okay. You can give diuretics, but in terms of the cocktail, because the diuretics, you don't want to give them the diuretics if they don't really need it. But in terms of the cocktail that we know about for the treatment of your high potassium, what is it that we use? What is the standard of care? We use the insulin with the dextrose. What else? Insulin pushes back potassium into the cell. Good. What else do we use? So we use the insulin with the with the dextrose. We use the calcium. What is the calcium for? What are we using the calcium for? We use the calcium gluconate. Why are we giving the patient with high potassium calcium gluconate? We give it to stabilize the heart. Okay, so Ashley says antidote. We give it to stabilize the heart, because remember what happens with high potassium causes excitability. So yes, the heart is going to be like, too excited. So you don't want this patient to go in any form of arrhythmia, cardiac arrest. So you give the patient your calcium gluconate. So you're going to give your insulin, your calcium gluconate, and the dextrose, and that's your cocktail. You can see them do the albuterol inhaler, and you'll also see the K-oxalate as well. But the cocktail is usually the dextrose, the calcium gluconate, and the insulin. And just know how those work. Just know how they work. The insulin is going to push the potassium back into the cell. The glucose is like, it's a transport. And then your calcium is going to protect your heart. So if you're supposed to ask what is the priority for that patient, if you're asked what is the priority for that patient, what is going to be the priority treatment for that patient with hyperkalemia? You have a patient with high potassium and you're supposed to be treating that patient. What is the priority? The patient has a potassium of 7. What is the priority for that patient? Is it the insulin? Is it with the dextrose? Is it the calcium gluconate? Is it getting the patient on the EKG monitor? Or is it, let's say, give the patient some normal saline? What is going to be the priority for that patient? Chem says calcium gluconate. Calcium gluconate. Okay. Think of it. If the potassium is high, the priority is what? You want to prevent any life-threatening arrhythmias. So what is going to cause, what is it that you're going to give the patient to prevent that or lower the risk? It is going to be the calcium gluconate. So go ahead and get that calcium gluconate on board. You put your patient on the cardiac monitor, then you can go ahead and address the insulin. Okay. All right. Wouldn't we give fluids first? So Shan is asking. So think of it, Shan. So you have the patient, if the potassium is high, you give the patient the fluids. What is going to be happening? The patient is getting the fluids. It's not doing anything for the patient. The patient is still going to be there either overloaded with the fluids and the heart rate is just increasing, or the arrhythmias is just increasing. So the patient's safety is still at risk there, right? The patient is going to probably die on you just the same. So unless you have a reason to give your fluids, you go ahead and give the fluids. But for your hyperkalemic patient, that is not priority for the patient. The priority is to get the calcium, stabilize the heart, then you work on getting the potassium into the cell. Yes, Daniel. Calcium gluconate to achieve homeostasis. Fluid overload tachycardia with bradypnea. Maria. Yeah, unless fluid is indicated, but even if the fluid is needed for the patient, the priority is going to be what? Cardiac is going to come first. The heart is going to come first, right? So if you're going to be looking at the high potassium, if you're going to look at the high potassium and the volume, yes, you always want to try to correct the issue. So just think of it, which one of them is going to kill the patient first? So that's what you always ask when it comes on to your priority question. Trying to find the answer and say, okay then, what is going to kill the patient? And then from there, if you're able to find that, then you go there. Fluid will cause increased heart rate due to expansion in the volume. Further risk. Yes, oops, it's me. So the arrhythmia is going to be the problem. So in order to fix the arrhythmia or correct the arrhythmia, decrease the risk for those arrhythmia, the cardiac arrest, you need to get that calcium on board. The patient needs the insulin, but the calcium is what the patient needs. Okay? Okay. Let's move on to this question here. Nikki says, hope that makes sense for you guys. Oh, thank you for the gift, guys. Yes, Ashley. What is the primary pathophysiologic event during an acute asthma attack? A, alveolar collapse, B, bronchial smooth muscle constriction, C, pulmonary edema, or D, loss of surfactant? B with insulin dextrose. Dextrose not to cause hypo. Dextrose is not to cause the hypotension, but it's just to cause hypoglycemia, to prevent hypoglycemia. But it is used as a transport. Just think of it. In order for the insulin needs something, right, to transport. So it's like a transport system there. That's what it's doing. So basically, it's transporting the potassium. So it's doing two things at once. So what is the primary pathophysiologic event during an acute asthma attack? We say B, bronchial smooth muscle constriction. Itzalia says A, alveolar collapse. Who said, well, A. Dr. to B says, well, it's A. So just think of it. For acute asthma, we know that it is reversible. We know asthma is reversible, right? So bronchial smooth muscle constriction, we know that it is constriction. Alveolar collapse is for what? Alveolar collapse is for your COPD, yes. Atelectasis, apimumu, good. C, pulmonary edema, we know associated with your pulmonary edema, your left-sided heart failure. D can be associated with what? Who normally have loss of surfactant? What conditions usually have like loss of surfactant? What conditions tend to have? So babies, you like your premature babies, yes. RDS. Good. So for your asthma, we know it's bronchial constriction and inflammation with your mucus that causes the narrowed airways. And we know that this one is your the one that is reversible. So if you have a patient here who has an acute asthma attack, if you have a patient here who has a acute asthma attack, what is the priority for this patient? What is the priority for that patient? What is the priority for a patient with acute asthma attack? Sorry, some remind me what that means. What's the priority for the patient with your asthma attack? See SABA. I see NEPS treatment. Okay, so Fabulous is airway management. I want you guys to be very specific though. All right. So you have a patient with asthma attack. What is the priority for the patient? Albuterol, because we know that with asthma it causes what? Bronchial constriction. So the priority is gonna be your albuterol, your SABA NEBS. Good. Because what is so I see corticosteroids. So the corticosteroids is for your inflammation. So between your corticosteroids and your albuterol, which one is priority? So if you're indecisive about your answer, always come back down to okay, then which one is priority? The patient is having bronchial constriction. Which one of them is gonna open the airway? The patient needs it. Which one is gonna be priority? It's gonna be your albuterol, your SABA. You give them together. Yes, they give them together. But you want to make sure you open the airway. You want to open the airway because it doesn't make sense you try to give your rescue first. Open before calming. Yes, doesn't make sense to try to give your oxygen and the airway is like constricted. That's not gonna really help with anything. High flow oxygen works fast until the bronchodilators kick in. But then you can be given, depending on the severity of the constriction, because if the person is having silent lungs, then there's no airflow. So you can give them that high flow oxygen, but it's not going anywhere because they are so constricted. Yes, Janiel. So oxygen can't get in if it's constricted. So the priority is gonna be your bronchodilator. But if it is acute, they need the medication. Acute, they need their medication. So you open the airway, then you give the oxygen. I know we have a tendency to be like, throwing on, but not because we are in the habit of doing certain things. It doesn't mean that that is priority. So just always think of, it comes back down to the same thing, the pathophysiology. Just think of the pathophysiology behind and the priority. And if you're able to answer that, then you'll be able to answer the question. I think someone was asking about surfactant. What is surfactant? What is surfactant? What is surfactant? Someone was asking about surfactant. So it helps with preventing the alveolar collapse. I think I saw someone had said that for drowning. Like persons who are drowning, yes, they lose their surfactant because of all of that water that gets into their lungs. So it's like a sticky. Reduce surface tension on the lungs, prevents alveolar collapse. Expected side effects of albuterol. High blood pressure. Yeah, it's gonna increase. It increases your heart rate, can increases your blood pressure as well. The coating on the lungs, premature babies. How many rounds of SABA they give before they administer magnesium sulfate? Whew. How many mags of, let me see. That one. Well, let me look it up. Oops, it's me. Let me get my little thing here. And a lot of times we do 3 rounds, but let me see if that has changed. And it's always dependent on the, you know, the provider and the patient based on your assessment. Yeah, but usually it depends on the severity, and but we normally do like 3 rounds, and then if they are not responding, then we can go with the magnesium. But if it's severe, then sometimes we just go ahead and start them on the magnesium. So you start them on the magnesium, and we can always, yeah, sometimes we'll start them on the magnesium depending on the severity of when they present, and then they will continue to get the SABA while they're there. So frequency. Yeah, so that's what I know. So usually it's every 20 minutes for 3 doses before the magnesium, then they continue. You can repeat your SABA treatments, or you can have continuous nebulization plus the steroid. The magnesium timing is usually generally after 1 hour of intensive conventional treatment. But magnesium is not for, you know, like your mild or moderate exacerbation, but it is for severe or life-threatening. So if their FEV1 is less than 30% predicted or continued severe distress. So as I'm saying, based on, you know, when a patient comes in, if that patient chest is sounding, you know, silent, then you can always go ahead and start doing that and treat the patient along with, you know, getting the patient either intubated and start getting those continuous treatment going. So why do patients with liver failure develop hepatic encephalopathy? So we have why do patients with a liver failure develop hepatic encephalopathy? A, increased glucose in the brain. B, accumulation of ammonia. C, excessive bilirubin deposition. Or D, decreased cerebral perfusion. BBB Aicha says C, excess bilirubin deposition. Accumulation of ammonia. So the liver can't detoxify, so you have the buildup of the ammonia, and it crosses the blood-brain barrier, causing altered mental status changes. Okay, so when you see a patient coming in and they have liver failure, that's one lab you want to make sure you get your ammonia sample. Always say, hey doc, you know, this patient have liver problem. Can we just go ahead and get an ammonia? Or if you realize that the lab enzymes are elevated, go ahead and get your ammonia. What labs are you anticipating for this patient? So you have a patient with liver failure. What enzymes are you anticipating to be elevated? Okay, so Trace Sizzle says CMP. All right. I want something different from your CMP. I want something more specific for your liver failure patients. Okay, so AST, ALT, yes. PUN, good. Liver function test, good. So yes, your liver function test, you want to keep an eye on. BUN is kidneys. So your liver, you want to keep an eye on. Would you be concerned about your amylase or for this patient? No. Okay, your pancreas is your amylase and your lipase, so maybe a little. Okay. But definitely for your liver failure, you'd want to go ahead and look at your liver, your liver function, your AST, AL, amylase is pancreatic. That's why you give them neomycin. BUN is more for hydration. Good. Okay. So what else? Let's move on to this question. Oh, we just reached a question 10? No, so Jamaica would have said on a skylark. Eh? What is a common pathophysiologic feature of all types of shock? What is a common pathophysiologic feature for all types of shock? A, decreased tissue perfusion. B, hypertension. C, increased oxygen delivery. Or D, bradycardia. What is common to all types of shock? Let's see. I am Hitty says D. Keek says B. What is most common to all types of shock? What we know about shock? Dine says D, bradycardia. Think of it. The pathophysiologic feature that is consistent with neurogenic, septic, cardiogenic, all of the different shocks out there. Which one of them show up on the board right now to you? A, because of lack of blood flow. Shy, welcome. Miss Cooney, blood loss. Which pathophysiologic feature is common to all types of shock? It's A. Dine says it's A. Remember, shock, failure to perfuse your tissues, leading to cellular hypoxia and end organ damage or failure. So the one thing that is common to all types of shock is decreased tissue perfusion. So regardless, neurogenic, septic, hypovolemic, cardiogenic, at the end of the day, they're all having problems with perfusion. Okay, so that is the one thing that is common with in terms of the pathophysiology. The cause might be different, but in terms of the pathophysiology, the underlying problem, all of them is because of this, is resulting in this decreased tissue perfusion. We'll definitely be coming back. Not a problem, Katie. Thank you. Thank you. All right. And so, hypertension. So if you have a patient that is in shock. I know I saw somebody with A. Pustain says A. Just think of it, Pustain. When you have a patient in shock, do you normally have a patient being hypertensive or hypotensive? Okay. Mostly hypotensive. And then if they are hypo, if they have decreased tissue perfusion taking place, because we know what is happening in shock, increased oxygen delivery, we know the body is in shock. Everything is going to the major organs. So what is happening? You're going to have decreased oxygen delivery to other organs, right? So this is going to be decreased O2 delivery. And then when the body is compensating, what is happening? Is the patient usually tachycardic or bradycardic? The patient is tachycardic because the heart is compensating. Good. So one thing you always ask yourself is, what is failing first? When you think about the heart, think of, fluid backing up. The lungs, think of gaseous exchange, kidneys, perfusion, and the brain, oxygen. And then from there, you'll try to use those to answer your questions. All right. I think I hear some bedtime now. Bedtime. Next time I'll wean you guys properly. Right? Oops, it's me. Abunge. Bedtime. Oh Lord. Next time. I will wean you guys properly. I think I had about some select all that apply questions. Let's do this one. One last one. And then that's it. Which pathophysiologic changes occur in left-sided heart failure? Select all that apply. A, increased pulmonary capillary pressure. B, decreased cardiac output. C, peripheral edema. D, pulmonary congestion. E, right ventricular hypertrophy. Select all that apply. Remember, for your select all that apply, if I only one you know, I just one you know. Because if you do two and you get one wrong, you lose points for it. Okay? So, and treat each answer as true or false. So start off and say increased pulmonary capillary pressure. And you work with it like that. So which pathophysiologic changes occur in left-sided heart failure? We know that has to do with the lungs, right? L for lungs, right for the rest of the body. So L for lungs, left, L for lungs, and then right side of the body. So we have A, D, B. So increased pulmonary capillary pressure, A, B, D. TJ. So we have ABD, blood backs up into the lungs, causes your pulmonary pressure to increase. Then you have the left ventricle can't pump, so you have your decrease in your cardiac output. Good. Then with D, fluid in the lungs causing pulmonary congestion. C is more for your right-sided peripheral edema. So the rest of the body, so that's for your right-sided. And then for E, right ventricular hypertrophy, it happens later if heart failure progresses, not necessarily primary left-sided. Okay. So the answer is your increased pulmonary capillary pressure, decreased cardiac output, and your pulmonary congestion. Okay, and that's the end. That's the end of the pulmonary, has to do with the lungs. Yes. Alrighty, thank you guys for tuning in. It was nice having you here. Bye. Kim, good night. Enjoy your night. My son wanna sleep. Yeah. Not a problem. I will see you guys on Wednesday? Yeah, I'll see you on Wednesday. You're trying to say bye? Yes. All right, enjoy your night, guys. Bye. And as I say, if you want the full length of the live streams, they're posted on YouTube. So you have to go over there and subscribe. You have to go to YouTube and subscribe to the page to get the full length of the live streams, all right? And watch them at your own convenience. All right, then, bye. Not a problem, Pustine, sugarcane. All right, bye. Are you finished doing a 2 times table?